Good morning. Thank you all for coming early on Friday morning to join us. We expect that we'll have a few more trickle in, but in the interest of time, we're going to go ahead and get this session started. We're very excited to have a great group of speakers with us today. So on behalf of myself and Chelsea, good morning and welcome to day 2 of NACFC. My name is Lauren Lyons. I come from Connecticut. I work at Yale New Haven Children's Hospital in the Pediatric CF Center. And Chelsea comes from the University Hospital's Cleveland Medical Center. And today we're really excited to talk about back to basics, or coming back to hopefully giving everyone a few very practical nuggets to take with you in your clinic or in your practice. So just that we have no disclosures today. And just a quick second for y'all to take a look at this picture and tell me how often, those of you who work in a clinic or even in a busy inpatient or outpatient practice, how often do you feel like this, right? Maybe not 2 phones, but like someone's asking you something here, you have a family that needs this, you have a doc that wants that, the nutritionist is interested in this. And I think we can all relate a little bit. When you do a PubMed search of physical therapy and cystic fibrosis, the top hits come up with a myriad of topics like exercise and airway clearance, quality of life, physical exercise training, and pulmonary rehab. But then we know there's also so many other things that we can offer, as we heard so much about yesterday and in previous conferences, like pain, incontinence or incontinence, strength and bone health and pregnancy. And so there's so many pieces that we can bring to the table. Sometimes, I know personally, it's hard to figure out where to start and where to prioritize. And add on top of that we're always asked to do more with less, right? Our patients, we've already heard, we know there have been some great QI projects, but our patients are universally complaining about that clinic visits are too long. It's exciting to have new additions to the clinic team, but that means there's more faces to see, and with a hope to make that time that they're in clinic even less. And then the opportunity, but the challenges of telemedicine, and that's here to stay. So our session objectives today is to give you some practical tips and ideas to take back to your clinic. And in particular, we hope to target 4 areas. Looking at strategies for quick developmental screening and parent education for our youngest patients and families. Talk a little bit about pelvic floor and continence throughout the lifespan. Look at the role of physical therapy in the other end of the life spectrum with our adults and our older adults, in particular as it relates to posture and exercise. And then wrap up with giving you some very practical and exciting resources about things that you can give patients and families to take home to use in their day-to-day. So we're very excited to have a great group of speakers with us today. And we're going to start off. Yeah, if you want to do that piece. We're going to start off with Kathy Van Drew, who is a physical therapist from board-certified pediatric physical therapist who received her doctorate in physical therapy from Virginia Commonwealth University. She's a level 4 physical therapist at the Children's Hospital of Richmond at VCU Health, with 20 plus years of experience in pediatric and adult CF care, both in inpatient and cardiopulmonary rehab. She was excited to receive the 2022 CFF grant for physical therapy and joined the CF care team at that time. She has an extensive background in multiple publications in infant development and parent education. And just to make sure nobody's sleeping, a little fun fact is that she spent her summer doing some rock climbing in Whistler, British Columbia. So, Kathy, welcome.
Good morning. Thank you so much. I'm so excited to be here and talk to you about developmental assessment of infants and young children in the CF clinic. I have nothing to disclose. So before I began working in the outpatient pediatric CF clinic about 2.5 years ago, my primary area of interest and expertise as a physical therapist was in infant development. I brought with me 20 years of experience from NICU, acute care pediatrics, NICU follow-up, developmental follow-up clinic, and developmental research. My experience with CF was from the acute care side and pulmonary rehab. So in the acute care setting, we typically consider kids with CF who get admitted with exacerbations to be developmentally appropriate. They can transfer, they can get out of bed, run in the halls, up and down the steps. So the focus of care has always been exercise tolerance and activity tolerance, strengthening posture, all the things. I never really thought a whole lot about development and developmental delays in kids with CF. So when I first started working in clinic, I was really excited, a little overwhelmed with all the different tests and measures that you could do from 0 to 18 in clinic. But I was always really confident with infants and toddlers, and I made developmental assessment a priority from the start. So it wasn't long before something really started to kind of blow my mind, honestly. I've got these kids on a 3-minute step test. These are the older kids. And I'm finding that they couldn't maintain single leg stance to step up onto the step, right? Forget about keeping a reciprocal stepping pattern, and definitely couldn't keep up the beat of the metronome. Now, this definitely wasn't all kids, for sure, but it was more than I expected. So I got to kind of start considering maybe doing some balance and coordination testing with them. I was also really surprised to see how many kids on the caseload were diagnosed with autism, or I thought maybe had signs of autism. I don't know why this surprised me, because 1 in 36 children in the US are now diagnosed with autism. And unfortunately, the mutation that codes for the CFTR gene doesn't immunize kids with CF against developmental disorders such as autism, developmental coordination disorder, which is often associated with autism, developmental delay, and disabilities. In fact, they likely have an increased risk. And like most areas of peds PT, there's not a lot of research. You didn't see development on the list of topics that commonly come up when you search CFPT. I did find a few small studies, and they all basically point to an increased risk of motor delay in kids with CF and decreased motor performance. And Tomasino et al. Also found that low stature, low weight, greater than 60 days in the hospital, all resulted in a statistically significant association with motor delay. Similarly, Masato determined that kids with congenital heart disease, who we know are higher risk for developmental delay, the ones that had increased heart surgeries, longer hospitalizations, poor linear growth, and tube feeds, had significantly worse developmental outcomes on all aspects of the Bailey Bailey developmental scales of infant and toddler development. So what if they're a little delayed and uncoordinated? Why does this matter? Well, motor delay and decreased motor skill proficiency will limit a child's ability to participate in physical activity and exercise. So whether you were on team airway clearance yesterday or team exercise, I think we all can appreciate the many, many benefits of exercise. And I'm not going to go over all of those because it's definitely been drilled into our heads this week. And it's a big priority now in the CF community. We're really emphasizing exercise in the care of patients with CF. So we also know that establishing healthy habits in childhood is going to carry over to adulthood. And finally, in the era of highly effective modulators, people with CF are living longer and healthier lives, so it's important to really focus on the quality of life in addition to optimizing quantity of years. We all know that exercise improves quality of life. Okay, so the first 3 years of life is a period of very rapid growth and development, especially in the developing brain. Early intervention is based on the premise of early neuroplasticity. Theoretically, a strong framework of neural pathways provides building blocks for the future complex skills. But in order for EI to work, we must identify children with delays and disabilities as early as possible. So next I'm going to go over some outcome measures that I've been using in clinic and have found helpful and ways you may be able to implement them. I want you to know that they all have been researched and are valid and reliable. For the sake of time, I'm not going to go over all the psychometrics, but there's references to all the tests in my references if you'd like to read about them. Okay, so you know you're a nerd if you have a favorite outcome measure. Hands down, the temp is my favorite. I love it. I've used it for years. It's norm reference. It's a test of postural and selective control of infants. So you can do it as early as 34 weeks and up to 16 weeks. You start with just observing the baby in supine. You're looking for about 13 different movements, and then you're going to move the baby through different positions, sitting, prone, rolling, and supine, and you're looking for specific movements. What I love about it is it shows, if you can see on the picture, a progression of the skill from the least mature to most mature, which is really great for parent education, which I'll get to. The one downside I would say to using the temp in clinic is that the babies have to be in a calm and alert state. You can't have them fussy or sleeping, which can be a challenge. But if you can coordinate with your providers, I think you can definitely find a time in that 4 hours that they're with us that you could sneak in and do a temp. It doesn't require a lot of equipment. You need a score sheet. You can get a yellow duck and a red shaker off of Amazon, and I would just grab a washcloth from your linen closet. I prefer to do it on a mat on the floor, so I have a cheap little Amazon mat that folds up and I'll bring into the room. Another downside is it does require training. There's an online training course. It's about $400, and it's about 15 hours worth of training spread out over 3 months. But you can do it at your own pace. And I have a resident who's about to do the October, there's a live workshop. So it's a 4-hour training session split into 2 separate days. And the QR code for that is here. So if you are a physical therapist and you're interested in pediatrics, especially NICU and infants, I highly recommend getting trained in the temp. And I feel like it adds a lot of value to the CF clinic as well. My favorite thing about the temp is using it as an educational tool. So it's also been researched, as a teaching tool, and it's found to be not only effective, but a preferred method over brochures or lectures. I love like I said, the pictures are great for families. For instance, if you have a baby maybe struggling with prone, you can show, oh, your baby here is barely lifting their head up off the mat. We want to work towards this picture where the baby's pressing and weight bearing, and you can put a CF spin on it where they're building upper body strength, which is so important for breathing. Okay, the aims. This test has stood the test of time. It's really old, but it works and it's great. It's very quick, 58 items. It says observational, but you have to move the baby around a little bit. Again, I like to bring in a mat for this one. It does have a basal and a ceiling effect, so it's best from 4 to 12 months. Like I said, it's super quick. It's not very expensive. You do have to print out the score sheets. It does not require training, which is wonderful. I would practice, and maybe establish reliability with another therapist on your team. But this is another really, really great option. I feel like everyone could probably easily fit this into your clinic. Again, birth to 18 months, technically. Okay, so I debated for a long time on whether really to even include this test, Prechtel's General Movement Assessment. I've used it and I found it helpful, but I'm going to make it brief, and the reason is because the training is very, very costly and time-consuming. It's a five-day training course. It's guaranteed not to be located anywhere near where you live, so travel. It's expensive, but if you're a therapist and you're interested, especially in NICU and infant, it would be worth it, but not for CF clinic, because it's a test for cerebral palsy. And basically, general movement patterns in infants called fidgety movements emerge around 9 weeks and continue to 20 weeks. The absence of fidgety movements is highly predictive of cerebral palsy. So this is really helpful in early diagnosis of cerebral palsy. It's actually very comparative to an MRI. But most of our kids in CF clinic do not have risk factors for CP. However, like I said, the deletion that causes CF does not immunize them against other developmental issues. So there's a possibility. So what I recommend is if you have a kid in your CF clinic, a baby, with any risk factors for cerebral palsy, which would be prematurity, an interventricular hemorrhage, periventricular leukomalacia, low birth weight, and you're not GMA certified, call your NICU friends and find someone who is. You could easily have the parents take a video of the baby, and your GMA friend will tell you what they need. I'm not going to go over that. And have the parent email your friend. It's only going to take 2 or 3 minutes of their time, so you're not really asking a lot. Okay, another one that you won't use a lot in clinic, but again, I included these because early diagnosis of CP is so important. So if we can recognize the signs and recognize the kids at risk, I feel like it is valuable. This one doesn't require as much training. It's an 8-hour live course. There's lots of locations around, especially related to teaching hospitals. It's always free. The test is free. The training's free. But it's a neurological exam. And this one extends up to 24 months. It's very quick and easy, doable in clinic for sure. And I would be useful for the same population that you would use the GMA, anyone at risk for CP. Okay, now you're probably thinking, she has really lost her mind. I am not doing an entire Bailey in CF clinic. And you're absolutely right. I would never recommend that. That's way too expensive, way too time consuming. All those toys, this huge kit, totally impractical. But the cool thing about the Bailey is that you can do just one domain. So I've often used it for the motor section. That only requires really a ball and a step. And it's super quick, 20 minutes to do the motor section, especially if you're a PT, you're used to assessing motor skills in infants. I have also used the language. This required a little bit more prep. I had to go gather all the toys for that specific age, but it was really nice because the family was kind of not really sold that their child had a language delay, and I was able to say, yes, actually, they're 2 standard deviations, so we got them in early intervention. So I felt really good about that. Each subsection only takes maybe 20 minutes if you're prepared. But like I said, very expensive. So what I've done is just borrow it from NICU clinic. Definitely not practical to keep in your CF clinic, but if you have access, it's great. The DAISY, nerd alert again. I have to admit, this is my least favorite test, but I could see where it's useful for clinic. It's cost effective, it's much quicker than the Bailey, and again, you can just do one domain. It's technically an assessment tool, but I feel like it's more of a screener, which is why I don't love it. There's not a ton of items in each age category. So I feel like it doesn't give you a ton of information, but it's definitely better than nothing. Like I said, it's quick, it's much more cost effective, and you don't really need any specific materials. You do need toys and a book and some items, but you can just gather whatever you have available to you. Very easy to score and interpret. All right, the bot. So this is what I started using when I noticed all the kids struggling with the 3-minute step test. I convinced my boss to get the bot. Unfortunately, we got the 2nd edition, and I realized now they've come out with a 3rd, so cool. But the cool thing about the bot is that you can just buy the gross motor, which is what I did. And you can do within the gross motor just one subtest. So I've been focusing on balance and coordination. I've also started using the strength. I really like that as a strength assessment. And what I like about it is that it tells you, how far away you are from average or normal. I love the objective data. So the one thing I will say about the bot is really hard for preschool age. So it goes as low as 4 up to 6, or to now 25, the new one. But I don't love it for preschool kids. The items are really hard. So I would probably recommend either the DAISY or even the Peabody if you have that for 4 and 5-year-olds. And I'm really curious, as I was researching this, I found the Bot 3 brief is also going to be published in fall of 24. I didn't find any information about it, but it sounds like it could definitely be something worthwhile for our clinics. All right, developmental coordination disorder questionnaire. This is a great option if you have anyone that you suspect developmental coordination disorder. Like I said, it's highly associated with autism. It's a brief parent questionnaire. You can do it with them. You can leave it in the room. It covers ages 5 to 15. Very quick. It's free. Very easy to read and interpret the scores. I will say that is not used to diagnose DCD. So if you have a patient that scores at risk, I would recommend a referral to a developmental pediatrician or your physical medicine rehabilitation and definitely physical therapy outpatient. Okay, the MCHAT, I threw this in here too because I couldn't really talk about DCD without the MCHAT, I guess. And this is a screener for autism. I have not used it in clinic, honestly, because I just really haven't had any kids that we needed. I feel like I've seen symptoms in older kids. This only goes to 30 months. And your pediatrician should be doing this at 18 and 24 months. But it's an option if you have concerns for autism. Finally, the ages and stages questionnaire. I don't have this, but actually really want it. I think it would be perfect for clinic because it covers from birth to 66 months, so a huge age range. It has multiple domains. It covers all the things and adaptive skills, which would kind of cover the autism concerns as well. It's a parent questionnaire, so you could leave it in the room with a parent and they could fill it out. You can score and go back and talk with them at any time. It's relatively affordable and it seems very easy to score. I kind of looked at the score sheets and I really liked all the questions that they offered. So if anyone has experience with that, I would love to hear about it. Okay, I'm gonna end with developmental resources. So the CDC Milestones website, if you have not seen this, please go check it out. It's wonderful. They've recently updated their milestones. The CDC went and they gathered a bunch of data on kids' milestones and changed all the milestones to match an age so that every milestone listed in that age category, 75% of the children are able to achieve those milestones. So it takes the questioning out. So if a child is missing one of the milestones on the list, then you automatically refer to EI. So this is another great option. You could do sort of just a surveillance with your families too and check the boxes. But what I love about this is when you scroll down on this website, on the bottom, left-hand corner, there are PDF files that you could print off. And it provides not only the milestones, but on the back, you flip it over, there's tips for development. So if a child's coming in, say at a visit and they're 2 months old, I'll print off the 2-month-old, 4-month-old, and 6-month-old so that they can have what to look forward to. There's also an app, which is really fun, that parents can track their milestones. And pathways.org is another great resource. These were developed by therapists. So physical, occupational, and speech therapists developed this website. Very similar to the CDC, it breaks down milestones into different age groups. It provides so many videos and pictures. It's a really great tool. It talks a lot about tummy time and containers and what to look for torticollis. And they also have a really fun app. Okay, so in summary, in CF Clinic, I feel like we have a unique opportunity to be involved monthly with kids throughout their first year. Again, I'm not saying we're going to see patients every month. That would be a little bit much realistically, but I do try to make an effort to check in frequently in the first year on development. Encourage parents, work on tummy time, do all the outcome measures that I can. So my recommendations for you, if you're considering adding developmental assessments to your practice, is just start small. Maybe start with, the CDC checklist. The AIMS is another super easy option for the first year. And really just talk to parents too about their development. What are their child's strengths and do they have areas of concerns? Parents love to talk about what their babies can do too. So it's kind of a bright spot in the clinic visit. And if you're in doubt, just go ahead and make the referral to EI. And thank you so much for this opportunity. It's been great speaking to you today.
Thank you, Kathy. That was wonderful. I don't think this is on. Yes. Sorry. So we're going to open up for questions after each presentation. We do have the app that's open too. So if anyone wants to submit questions on the app, or if you want to come up to the microphone and ask Kathy a question, we're more than welcome to. Sorry.
I'll start it off. I work in a pediatric clinic, and we see our infants very frequently in their first year of life. So typically monthly, maybe even more often if we're worried about watching weight. Do you have particular time points that you would recommend doing developmental screening? Clearly, we're not going to do it at every visit, right?
Yes, that's a great question. I would save the temp until closer to 3 months. It's typically more reliable, and I think the baby's going to tolerate it better, and kind of let the parents kind of get used to like clinic, because it might add a little bit of time. The AIMS, I would definitely try to get at least one AIMS by 12 months. Like I said, I'd prefer to do it by 12 months as opposed to waiting to 18. And then maybe I would do like, a Bailey motor between 12 and 24 months. Kind of as a base, and then, kind of work towards the bot.
Okay, thank you.
You're welcome.
We have another question. How long does it take to perform the temp in clinic?
Well, I've been doing the temp for years, so I've kind of got it down to about 15, 20 minutes for sure. I guess if you're less familiar with it, though, it could take up to maybe 30 minutes max, I would say.
Okay, thank you. Okay, we do not have any other questions at this time.
I'm going to let you get off that easy.
Okay.
Throw one more out there. I'm just curious whether, in looking at the literature, the incidence of increased developmental delay in our children with cystic fibrosis, we know their initial birth course is very varied, right? Some have a very easy course, and some may have surgical intervention or may have a NICU stay. Was there anything in the literature relating what their early course was like to the incidence of developmental delay?
Yes, the patients who were in the hospital for longer had worse outcomes, more higher risk for developmental delay, which parallels other diagnoses, like the congenital heart disease.
Thanks.
I'm one of the physio from Belfast. I'm working in Ireland. And, last number of years, we are seeing lots of ASD kids in the CF population. Do you feel the same sort of pattern here? Or do you think that early CF modulating therapy makes some sort of impact on their behavior? Or because last year, maybe we diagnosed maybe 3 or 4 patients with ASD. Maybe before that, maybe 1 or 2. So there is a clear increase of diagnostic ASD disease in CF population. Do you feeling the same?
I have to admit, I haven't been in this CF outpatient clinic for long enough to really say if there's been an increase. Maybe someone else could speak to that, but I was very surprised to see how many we had on our caseload for sure. I don't know if anyone else has any insight into the increased prevalence. I think it's just being diagnosed a lot more now and early, which is great. So yes, we can get services early, get that ABA therapy started.
If there are no other questions, thank you, Kathy.
Okay.
So we're excited to bring up to the podium our next speaker. Caroline Chalonier is the lead PT at Maine Medical Center from Portland, Maine, and one of 2 primary PTs in the pediatric CF clinic. She received her doctorate from Duke, and in 2019 received the CFF Grant Award for Physical Therapy, and focused her quality improvement work in patient and family satisfaction, and also screening for continence and incontinence, as well as their management. She's a mentor for the CFF mentoring program, and also the physical therapy representative on the CFF Guidelines Steering Committee. And her fun fact is that her background is actually in chorale performance and musical theater. And if she hadn't become a physical therapist, she actually was considering a switch to music education.
I don't know how you did that, Kathy. I'm not that tall. Okay, good morning, everybody. So this morning I'm going to talk a little bit about pelvic health in CF and things to consider across the lifespan. So there's a ton of content here. I'm going to try not to breeze through it too quickly. I have no disclosures. So just a few things we're going to talk about: prevalence, signs and symptoms, sex and age-based considerations for screening, some useful screening tools or thoughts about how to screen in clinic if it's not something you're doing already, when to refer to specialty services, particularly some red flags that would be of concern, and some strategies for intervention, but we're definitely not doing a pelvic course right now, so don't anybody panic. So pelvic floor dysfunction. Just a brief reminder, this is your pelvic floor. This is where it is. These are the muscles. They're all pretty and they're colored, and we're not going to talk about all of them today because we could do an entire day talking about the pelvic floor and continence and all of those structures and the way that they work. But just sort of a reminder as PTs, this is what we're talking about. So pelvic floor dysfunction in CF, why does it happen? Most of the research will tell you that persistent coughing is the main culprit for pelvic floor dysfunction in this patient population that leads to progressive weakness of pelvic floor muscles. But what I will say, kind of going along with this, is it's not always weakness. If you've been to any of the talks in the last couple of years, we're also looking at tightness, we're looking at mobility. So it's not just give your patients some Kegels in the NAC and send them home and hope that it fixes the problem. We're also looking at altered respiratory mechanics and abnormal posture. So it creates imbalances in the muscles of the pelvic floor as well as in your trunk. And we all know how important the rest of your trunk control and your lower extremity musculature are for how your pelvic floor functions. If we're looking at general prevalence, there's a whole lot of studies out there looking at prevalence. Most of them are not that recent. There was one from this past year. In general, it ranges from 25 to 71% in females and in 11 to 41% of males. And this is fecal or urinary incontinence combined. It is greater than healthy controls across both age groups and sex. So no matter what, if you have CF, you are most likely at higher risk of having incontinence, period. So I did find one systematic review looking at prevalence and impact of UI and CF, and some things to note if you're thinking about risk factors or higher risk for incontinence is that it's typically more common in adults and adolescents, more common in females than males. For women, urinary incontinence specifically ranges from 30 to 76%, which is a pretty high number if you're thinking about that. And in men, it's from 5 to 15%. Still higher than the healthy population. And most studies don't have a clear association between CF disease severity, so FEV1, pulmonary exacerbations, hospitalizations, and urinary incontinence. So it's not necessarily true that the worse the disease, the worse the incontinence. It may be in a patient who's never had any significant exacerbation or hospitalization. Since we are talking about incontinence, just sort of a review in what we're looking at is most patients report stress incontinence in CF. So that's when you have high abdominal pressure and a weak pelvic floor or altered muscular mechanics in your pelvic floor, and you can't combat that increased pressure and you leak when you're doing activities. The amount that most people report in children and in adults is usually small. So a few drops is what a lot of the questionnaires will use as a quantifier. And the most commonly reported triggers are things like coughing, laughing, sneezing. But the three we want to pay the most attention to are physical activity, airway clearance, and spirometry. And these are all things we want our patients to do, right? So if the things we want our patients to do to keep them healthy are also making them leak urine every time they do it, are they going to be as likely to participate in those activities? Again, talking about some risk factors or things to be thinking about when you're looking at your patients, Again, we just said that systematic review found no necessarily relationship between disease severity, but there are some isolated studies that show increasing age and lower mean FEV1 is more associated with regular urinary incontinence. Again, that second study, comorbid urinary incontinence and increasing age are increased risk for fecal incontinence. So as we get older, and that's something we're talking about with all of our patients with CF now, we have more adults than we have pediatrics at this point. We have more risk for these things. I think as patients get older, the number of exacerbations, that FEV1, that all becomes more important when we're talking about an older patient. Another thing I hadn't considered, but that did come up in the literature, is that undiagnosed or poorly controlled CFRD can also contribute to urinary incontinence, right? So that should be something that might be flagging you in your brain. If someone has urinary incontinence when you're screening in clinic, maybe asking a few questions that might lead you down the, do we have something going on from a diabetes standpoint here that we haven't addressed? Some health impacts of incontinence, just to continue to hammer home why it's so important to talk to your patients about this, is that it limits patients from coughing up sputum, completing airway clearance techniques, participating in PFTs in clinic, and engaging in regular physical activity. The other thing is that it has a reduction in patients' quality of life. And it's not always a huge reduction, but it is noticeable on screening tools and in people's function. And a lot of patients don't talk about it because they're worried or they're embarrassed around the symptoms. But in a couple of the studies I looked at, up to 25% of patients stopped coughing up sputum or participating in their airway clearance because they were leaking every time they were doing it. Some things to think about when you're looking at your patients in terms of population specific, depending on if you work in peds or adults. In the general healthy population, and I know this is a little busy, but there's a whole initiative looking at women's preventative services, and I think incontinence tends to be much more heavily studied and looked at in females than males because it is much more prevalent. That in healthy females, general adult population prevalence is 25% of reproductive age women, 44 to 57% of middle-aged and postmenopausal women, and 75% of older women. So it really stands to reason that if you're seeing any females in your practice, it's probably something you should be screening for because these numbers are really high even in the general population. In the general population, obesity, previous vaginal delivery, and increasing age, also all really important. And a lot of these people are not being screened by primary care or seeking care. So you may be the first person asking somebody about this question. In CF, specifically in pediatrics, pelvic floor dysfunction is more prevalent in children with CF, both males and females, compared to healthy age-matched kiddos. Specifically in studies looking at girls with CF, stress UI, again, is most frequently reported. In kiddos, no association with pulmonary exacerbations or FEV1 is in several of the studies that are out there. So in kids specifically, disease severity does not correlate. Most common triggers are coughing and laughing. It can impact their ability to do airway clearance. And most patients haven't told anybody that they're experiencing their symptoms. Again, small volume, but still something impacting their quality of life. Pregnancy is what always comes up when we talk about incontinence, right? So up to 70% of women with CF who have been pregnant report urinary incontinence. 70%. It's a huge number. The big thing is that a lot of them were experiencing it before. So some things to consider in your pregnant patients with CF, and we have more and more of those out there now, is that why you have an increased risk of incontinence in general in pregnancy is because you have high abdominal wall tension as that baby continues to grow out. That increases your intra-abdominal pressure when you're just standing there, much less when you start doing things like coughing, laughing, airway clearance, stuff like that. So already an increased risk for more urinary incontinence or a start of urinary incontinence that wasn't happening. And then you also have this impact of an increased risk of constipation in our DIOS, because in pregnancy you have changes in your small bowel activity. So you add those two things together, and definitely an important thing to be considering if you're in an adult clinic working with patients who are pregnant. Some things to consider in these patients is that it's not just about addressing their pelvic floor, particularly in pregnancy. So you want to be thinking about mobility, training and strengthening throughout the spine and the lower extremities, as well as talking about pelvic floor muscle control and breathing exercises, particularly before pregnancy. It's a lot harder to start training these things halfway into a pregnancy than it is to start preemptively. So if you know your patients are planning for pregnancy, this is something you can start talking about. You also want to think about postpartum, is that pelvic floor and ligament laxity continues for at least 6 months is what's in the literature, but I'm sure any of us who've had a baby are like, that might be a little longer. So things to think about here. And always consider a referral to a pelvic floor PT. So they're not just going to talk to them about their pelvic floor, they're gonna get them ready for labor, delivery, postpartum, and look at them from top to bottom and all the way around. So I'm a huge plug for pelvic floor PT for every patient who is pregnant, wants to be pregnant, or recovering from that whole experience. In menopause, I'm gonna skipping these things. So the thing we're thinking of is we have more patients with CF now who are experiencing this state, right? So the presence of chronic lung disease is actually an independent predictor of incontinence in women. We've talked about that already. And in older women, that's even more significant. So if you have any patients that are in perimenopause and menopause who have also been pregnant, again, should be raising flags in your brain, something to ask them about. And then I didn't want to leave the men out of this conversation because I think they do get forgotten in a lot of these conversations. That UI is still higher in men. It's 15% compared to healthy controls in this one study. It's obviously those numbers are much lower than females, but still higher than the average population. And they have higher scores for anxiety and depression than those who don't have UI. So it may be impacting their quality of life, even if the prevalence isn't that significant. So let's get down to actually what are you going to do in the clinic? How do I screen for incontinence? And I put this on here because every single study I looked at said that UI is underreported, underscreened, and not talked about in most visits. Not necessarily in CF clinic, but in general with healthcare providers. So why screen? I feel like we've already talked about a lot of this morning, but increased prevalence in all of these patients, often underreported. They've never mentioned a symptom to anybody. And if we think about the burden of care that most of our patients with CF experience, I think anecdotally, a lot of them think that this is fairly low on the totem pole of all the other things that they have to deal with. If it's a little bit, it doesn't happen all the time, why talk to anybody about it? But we should be screening so that we can appropriately either intervene if that's in your wheelhouse or refer out if it's not, and it's perfectly okay for it not to be. I don't treat anybody specifically for pelvic floor, but we screen every patient in our clinic for it. We have conversations and education around it so that we know we're addressing it, even if it's not something that I as a PT am an expert in treating. And then the other thing, Kathy talked about it. We've heard it in a lot of sessions. We're trying to improve quality of life and overall health through the lifespan. And if they're experiencing urinary incontinence as an adolescent or a young adult, it's only going to get more challenging or more significant as they get older. So if you want to start screening in your clinic, some things to consider, if it's not something you're already doing, is what symptoms are you most interested in screening for? Do you want to use a standardized tool that's out there, or do you want to just make one that's the one you use for all of your own patients? When do you want to give the screening tool during clinic? In our clinic, the MAs, it's included in the clipboard. When they come in, we do it every 6 months, and it's just part of the clinic flow. They fill it out, and then it gets back to me before I go in to see them, but everybody does things a little differently. What are your next steps if you get a positive screen? So you sort of have to have a plan in place for, okay, I know somebody's having urinary or fecal incontinence. What am I doing about it? And then how to partner with your multidisciplinary team so that you can manage these patients going forward. There's a very long list here of screening tools. I am not going to talk about really any of them because there's a whole lot out there. The top 3 that are bolded are the ones you'll see the most commonly talked about in adults, particularly the pelvic dysfunction screening protocol. I'm not even going to try to say the name that goes with that. The third bullet there is used frequently by outpatient pelvic floor PTs. But all of them ask questions around How much leakage? When are you experiencing it? What type of activities? A lot of them will ask about constipation additionally, so some tools that you could look at using in your clinic. The other thing you could consider is just having patients do a bladder and bowel diary in addition if they say, yeah, I'm experiencing it, but we're not quite sure what's going on, to have them bring into their next visit so you can determine, is this really urinary incontinence? Is it nighttime bedwetting? What exactly do we have happening here? We use a screening tool that we actually made after looking at a bunch of them because we didn't feel like any of them were super peds friendly for our clinic, where we weren't asking anybody about it at all when we first started 2 years ago. And our screening tool just asks questions about, do you experience it? How much? How often? With what activities? And are you ever constipated? So that we can come at it from both angles. This is much bigger on our poster number 540 down in the poster hall, but this is just what our screening flow sheet looks like, very busy. The big thing to note from here, at least in our practice, is that every 6 months we're doing a urinary incontinence screen with all children over the age of 5. I'm a peds therapist. If they are positive for urinary incontinence, plus or minus constipation, they're getting a KUB, a reflex culture with a screening UA, and we are recommending outpatient PT if it's impacting their quality of life and they're open to it. And then we revisit it the next time they come in. We've got a couple of educational handouts we do around constipation, dietary intake, urinary incontinence, bladder health, all of that sort of stuff. And then there is that box in the middle is about referring to nephrology. We're going to get to that in a second. Or now. Right? So when do we refer to specialists? So great to be screening, but what if you pick up something that is not something you are prepared to deal with? So some red flags here, I'm not going to read all of them. People who are experiencing large volume continuous urinary incontinence, that would be a reason to refer out. Any signs of infections, concern, that's why we do, our urologist recommended a UA with a reflex culture. Let's make sure this patient doesn't have a UTI that's contributing to the urinary incontinence they're experiencing, right? If you have underlying questions of anything, underlying neurological disorders, things like that, we want to refer out for these things. Referral to pelvic floor. Any patient who screens positive for incontinence, constipation, or pelvic floor dysfunction, in my opinion, should be referred to a pelvic floor physical therapist if they are open to it. There's a lot of evidence to support using pelvic floor PT, and it's generally the first-line treatment for most pelvic floor disorders. Referral to nephrology, these come straight from our peds providers, so there may be some differences for adults, but if patients are having daily symptoms affecting their quality of life, no improvement in symptoms after a bowel cleanout, plus or minus a PT referral, an abnormal UA or culture, giggle incontinence, which is like full volume bladder leakage with laughing. It's not a little bit of leaking, it's a complete loss of bladder during laughing. That is not the same as stress UI with laughing. Non-monosymptomatic nocturnal enuresis, that means your kids who are having UI or other issues during the day and bedwetting at nighttime, not just nocturnal enuresis. Or nocturnal enuresis with a comorbid behavior diagnosis. So we were just talking about the prevalence of autism spectrum disorders in this population, something to consider. And then once you've screened for it, you've got it, you've decided if you need to send them to see somebody else, what do we do about it in clinic, right? So, unsurprisingly, limited evidence about the actual treatment of pelvic floor dysfunction in patients with CF. We know that it exists, but there have not been a lot of studies looking at specific treatment protocols or intervention strategies. So there's no clear algorithm for how to manage these patients with CF. It is reasonable to think about their bowel regimen too, which is why we talk about constipation. And some of the treatment strategies out there in the literature that have some support, pelvic floor muscle strengthening, postural intervention for the thoracolumbar spine, ribs, pelvis, all the things we're already looking at as a PT. Again, looking at some of the evidence around pelvic floor muscle exercises, effective in treating stress UI, improving endurance, reducing leakage, first-line treatment, so again, a pelvic floor PT referral, and significant reduction in incontinence episodes. General ideas, education, any type of education you can give your patients, it might make them a little uncomfortable. It might make you a little uncomfortable to start talking about it. It did when I first started having to go in and trying to figure out how to talk to kiddos about this, right? But we're really not going to make an impact if we haven't looked at how to teach people about these things. Partner with your dietitian, your psychologist, your social worker, because there's usually other factors contributing to urinary incontinence, their dietary intake, kind of how they're feeling about it, stress that's going on in their life. Focus on strength and mobility of everything. Look at breathing strategies, so looking at diaphragmatic breathing, core exercises, all that good stuff. And then think about toileting posture and voiding schedules, all of these things. So it's huge, right? This is why we refer to pelvic floor fatigue. I'm going to run out of time. But the last thing for peds is to also consider referring to OT, because if we're having struggles with toileting and voiding, some of that stuff can be sensory ADL related. So always think about bringing in your multidisciplinary colleagues. And then definitely a very quick list, but some things to think about from a pelvic floor standpoint if you're working with any of these patients. Mary Massery, Julie Wiebe, and Herman and Wallace are all great educational resources for therapists who want to learn more about the core, the pelvic floor, postural control, and function, if it's something you want to feel more confident in assessing and treating. From our colleagues from Children's Hospital Colorado, The Poo in You is an excellent video. I don't have time to play it, but if you have kids who are experiencing constipation and not understanding how your bowel works, that is a great video. Everyone should look it up. And then if you're working with patients who are pregnant or postpartum, Expecting and Empowered is a great app. It's done by a couple of physical therapists. It's got a really big emphasis on breathing, postural control, pelvic floor control, all of that stuff from prenatal all the way through postpartum. And a few of us in this room have used it and think it's great. Not that I am promoting them in any way, shape, or form. And there's a whole lot of references there. And that's my clinic team, who's really comfortable talking about bowel and bladder function now, because we talk about it all the time. There we go.
Thank you, Carolyn. That was fantastic.
Thank you.
Really good. So you have several questions coming.
Very fast. It's a lot of material. Lauren didn't think I could do it, but I did it. Barely.
You did great. So the first question is, why did you choose age 5 to start screening for incontinence?
Typically, kiddos are not expected to be continent until age 5. And actually, nighttime continence is sometimes closer to age 6, 7, I would say. But daytime continence is expected around when kiddos are starting school, so kindergarten age.
Great, thank you.
Yeah.
And then somebody wants to know if you can share your educational handouts on the listserv.
Ooh, yes, I can do that.
Okay,
Yeah.
quick and easy. Oh, sorry. Oh, go ahead. I'm sorry.
Hi, I was just wondering if you could talk about your thoughts on incontinence now in this post-modulator world. A lot of the studies were done, obviously, before the modulators were here, and we're seeing less chronic coughing. Obviously, they're still doing their, well, debatable if they're still doing their airway clearance.
Yep.
But they are living longer, so the age consideration. So I was just wondering if you had thoughts on that.
Absolutely. So I think it's definitely becoming more important in our older population, because those patients have already experienced the number of exacerbations, coughing, airway clearance, the cumulative over their lifespan to have contributed to probably significant pelvic floor dysfunction at that point. Really important in adult patients, and probably going to stay important in adult patients until this cohort of kiddos that are sort of in the middle, that started modulators maybe as teens, but already had experienced a lot of hits to their pelvic floor, so to speak, are kind of aging up. The younger generation, I think we're going to have to see what happens. You know, if you look at some of the things about pelvic floor dysfunction, just in general, the general kiddo population, I actually think we don't pick it up as often as we should in general pediatrics. So I think it's probably still an important thing to screen for, even as we're in this modulator era, because again, it's not something people are talking about. So even if it's not related to their CF anymore, if you're the only physical therapist this kid's seeing, and you happen to pick up that there's something going on that they haven't told their parents, that nobody really knows about, and we can address it, I think it's still important to look at.
Thank you.
Yeah. Yeah.
And someone wants to know how you facilitate throughput to a pelvic health specialist. Oftentimes, our patients live some distance from our facility, and there is the other costs associated with physical therapy.
Yes, the cost with outpatient PT is always a barrier. We are lucky that our pediatric nephrologist had actually already done all the work for us and had a list of all the pelvic floor PTs that they refer to that they kindly shared with us, and I've added to it. One thing I would look at is if your state APTA chapter has a pediatric special interest group, that would be one way to try to look at getting a better handle on who in your state or in your geographical area does pelvic floor for peds. I think it is a growing area of peds PT practice, but it's definitely not something everyone has access to. I do know that a few of our therapists we refer to do telemedicine, which is not the most ideal way, but it is a way to get you started. And usually I let the patients and families guide on whether or not they really want the referral. Some kiddos, it's not impacting their quality of life enough that they're willing to do the extra appointment, the extra time, but I always make myself available to talk about it, to educate, and to do the referral if we need to. But we leaned on some of our other providers to help us with developing that network.
Okay, great. How many more do you think? We have a couple more, but, oh, sure.
Just a little shout out to respiratory therapy colleagues. There's a fair bit in the beginning about the incidence of stress incontinence during Spiro, right? Which we expect our patients to do as part of clinic visits. Any specific tips, hints that you might give to our respiratory colleagues of how they might give any suggestions during Spiro to help our patients?
So if you're willing to teach your RT how to teach patients to do a NAC, that's preparatory, activating your pelvic floor before you do something like coughing or a PFT or things like that. If your RT is willing to learn it and your patients are willing to talk about that with your RT, that's one way to approach it. Otherwise, I think sometimes it can be a little challenging because it is a sensitive subject to talk about with patients. So you would just want to make sure that your RT was in a place. In clinics who don't have a PT, that would be a great avenue to go down, your RTs could potentially be doing a little bit of screening if they are feeling comfortable with that. But I would probably use some caution with having RT talk too much about pelvic floor during Spiro, just because it can often be very triggering for patients to talk about that stuff. But yeah. Oh gosh, I'm in the hot seat here. Okay, I'm ready.
A lot of questions.
I'm ready for it.
Okay. I noticed the date on most of the pelvic floor studies predate TRICAFTA release. Do you feel this might affect study release and prevalence now?
I hope so. I think I would love to see a prevalence study that happens like 5 years from now, when we can look at kiddos that have been on modulator since the beginning. It's always going to be there, right? We talk about how many patients don't qualify for modulators, don't tolerate modulators, don't have limited benefit from modulator. So I think that's the other thing to consider, and to screen everybody regardless of modulator status. But yeah, I think that the prevalence could look different. The other thing to think about is, the prevalence in our adult population may not look that different because it's unfortunately really common in women, whether you have CF or not. Things to look forward to. But yeah.
And someone wants to know what your poster number was.
540.
Okay.
I'll be down there this afternoon, I think.
Okay.
Yeah.
We don't have time for all the questions.
But I'll be here after. You can find me. I'm easy
find
to
Caroline
find.
after, and
Yeah.
she will answer. There was a couple more that I think you might be interested in, but we'll
Move
keep it
things along
going.
for
Yeah.
sure.
Maybe able to answer those on the app too, so people can see them on the app. So if
Okay.
something wasn't unanswered, you.
If I can figure out how to do that, I will do that. Otherwise, I will be right here. You can find me afterwards. That's good too. But yeah.
Thank you so much.
Thanks, guys.
That was wonderful. Okay, so I'm going to introduce Alexander Bo Arrow, who is a physical therapist with Good Shepherd Penn Partners at the Hospital of the University of Pennsylvania in Philadelphia. Bo graduated from the University of Scranton with his DPT in 2017 and has been practicing in various areas of acute care since graduation. He currently works in the outpatient CF clinic in the Heron Lung Center, in addition to the outpatient post-lung transplant clinic. And to go along with our fun fact for our wonderful speakers, Bo is signed up for 2 marathons within 3 weeks of each other, which he says was accidental, but I don't know about that. Chicago and New York, which are coming up, so good luck, Bo. Okay, there you go. And you know how to. Yeah. Yep. You can use that or that. Either way.
For this.
Yep.
All right. It truly was accidental, I promise. I'm not that crazy. Good morning, and thank you for coming out this morning. I do want to start with thanking both Chelsea and Lauren for all their hard work and patience that they did to putting this together. And I think my favorite part about this being a part of this presentation was trying to come up with the title. And I know it's not that catchy or really stands out, but I think when I first started in the CF clinic, I would frequently hear providers say, you know, patients didn't want to stay for you, or they didn't need PT, or the ones that would let me into the room, they'd be like, I don't need PT, or I don't have time for you. And so about a month ago, one of those same patients, you know, after time and time again of them saying no, about a month ago, they, when I walked in, they say, okay, Bo, what can you do for me? And so today I'm here to talk to you about what I do as a physical therapist in an outpatient adult CF clinic. All right, I have no disclosures. So I'm going to just go over some typical exam techniques that I use during my eval. I'll then go into some conditions that I screen for, including osteoporosis and osteopenia, urinary incontinence, and vestibular dysfunction. And then I'll wrap up with who I refer to and sort of when and why I do that. So before I go into an exam room, I'm going to look at the past clinic notes. I'm going to look at their social history, current equipment, and current level of function. In terms of relevant tests and labs, I'm going to look for PFTs. I'm going to look at a recent DEXA scan or look for their imaging, like a chest X-ray. I also will look for other imaging, like an MRI, a CT, or an X-ray of like an orthopedic injury, because I have a lot of people coming in with injuries nowadays. Then I'll go through a systems review. I try to annually do an aerobic capacity or endurance outcome measure. And then finally, throughout this session, I'll do some screening. This is a subjective survey they give out at the beginning of every session. It's called the Barriers to Being Active. It's by the CDC. I do have a link at the end if you're interested. It's 21 questions, and I find that my biggest role in the clinic is helping our patients incorporate more physical activity into their daily lives. And so I find that this survey leads to a really nice starting point in that discussion. And so I've also found that most of our patients aren't in that action phase or like readiness to change, and that most are in that contemplation or thinking about it. And so this kind of breaks down where their barriers are. And so it gives me a good idea of where I can jump in and help. So for my systems review, I'm doing some of the things that many of you are probably already doing. So I'm auscultating their lungs, listening for any crackles or wheezing. I'm looking at their breathing pattern and seeing if they're using their diaphragm, like I hope that many of us instruct on. I'm also looking for any accessory muscle use. I look at their hands and feet for any edema. I'm looking at their capillary refill. I'm also looking at their fingernails for any clubbing, which I've pictured there on the slide. So I know many of you here have attended the other sessions, and we've talked a lot about airway clearance and whether they're doing it, whether they're doing physical activity. Regardless of where it goes in the future, I'll still be asking about airway clearance. And so specifically, I'm asking, what are you doing for airway clearance? Are you using any equipment, or are you doing activity? If you are, how often and for how long are they doing it? I'll get into it in the next slide, but the forced expiratory technique, the huff and cough, is really important, and that's where I'm doing my main education on airway clearance, to be honest. I do go quick run through some of the medications, and although some of my colleagues at CHOP or some of my colleagues within my team do a really good job of educating, I'm finding more and more so now that I'm reminding people, especially with an asthmatic component, that, hey, you can use that bronchodilator, you can use an albuterol before, and that takes away some of that chest tightness when they're doing some activity. Otherwise, I don't do this that often, but cough assessment is another tool that you can use in your toolbox, that especially for those people who are having a cough that's not productive, but you can hear it on auscultation, but you can really identify which phase is impaired and then kind of go from there. So hopefully many of you attended the debate yesterday, which I thought was really well done. So I won't go over all of that information. I did list a few of some of the benefits of physical activity. I know Kathy went over it earlier as well. But some literature has shown that physical activity alone does not provide the expiratory flow required to expectorate sputum. And so that's why I'm educating all of my patients to do huffing or coughing, either during and both after activity. And so some common things I run into are, well, I'm at a gym or I'm on a team or I'm in the dance studio and I don't want to. So some of the things I suggest are, stepping out, going to the bathroom. For some of my younger patients, like those teenage years, I'm also, trying to normalize it and encouraging them to start to talk about it, because I feel like in that age range we're starting to become more open to things, and I think that people are more open to it once they just know more about it. So my musculoskeletal exam consists of some chest wall mobility, some posture and range of motion and strength. So in that upper left-hand corner for you guys, you see Rich Severin, who was a speaker here last year, if any of you attended. He's assessing the chest wall mobility with palpation. He's looking for any pain or symmetry. Otherwise, I sometimes will do some rib springing or assessing rib mobility. In the bottom, you can see a PT is doing rib mobility as an intervention there. Otherwise, you can assess rib mobility by having them stand up and measure both in standing at rest and then side bending with a tape measure. Another technique that I'll use is just to look at chest wall excursion. If I'm finding that there's some asymmetry on my palpation exam, I'll use that same tape measure, wrap it around their xiphoid process, have them take a deep breath in and out and kind of subtract the difference. Otherwise, posture, I'm looking at it throughout the entire session. Common things I see are forward head posture, rounded shoulders, thoracic kyphosis. It's not abnormal to see abnormal or lateral curvature of the spine. I will have them stand up and do like a dynamic assessment where I'm having them lift their arms up in front and overhead. I'll have them side bend. Recently, I've been having them bend forward and backwards and kind of doing a literal shift because I'm having more patients come in with back pain. And so through that assessment, I'm getting a general spine mobility. I'm getting scapular mobility, rib mobility. I'm also looking at flexibility of the hamstrings, the low back muscles, the whole trunk. So it gives me a really good picture. I can also use a tape measure in some of those instances to more objectify some of my findings. Due to my clinic space, I don't have a posture grid, but know that that's another option to be more objective and see changes over time. Otherwise, for strength, when people are coming in with a certain pain or injury, I'm doing some manual muscle testing as you normally would in an ortho clinic. If anyone attended the research session yesterday, Taylor Lewis was mentioning how hand grip strength can be linked to SVC and MIP. So I know that that's a gold standard, especially in some clinics. I am more interested in quad strength, and some literature has shown using either an isokinetic machine, which can be pretty costly, or using a handheld dynamometer can be useful in being objective in determining quad strength. So that's something I'm looking forward to doing in the future. So many of our patients have had lung infections and therefore been prescribed IV antibiotics. A certain type of antibiotic called aminoglycosides can cause ototoxicity. These patients can then describe postural instability or oscillopsia, which is essentially when they report that the objects in their visual field are shaking. They may also say that they have blurry vision or difficulty focusing. It is important to note that if these antibiotics some most common, I've listed on the slide there, if they're continually prescribed and taken, they can lead to increased risk and increased impairments. And so to screen for this, I'm using the dizziness handicap index. And I've also sometimes performed a HIT test or a head impulse test where you're tilting their head down and you're moving their head side to side while they're focusing on your nose. If either of these tests are positive, first I'm discussing with the team to hopefully find another alternative and to stop the medication. But a lot of times the symptoms don't always go away after stopping the medication, so I am referring them to a neurologic clinical specialist. Caroline, thank you. You gave a really great presentation, so I won't touch on this a lot. In my practice, I've seen the shift going from coughing to now pregnancy. So I do a lot of education on diaphragmatic breathing. One of my pelvic floor colleagues showed me this GIF and I loved it. I saved it on the computer. I use it a lot. I think that it really clearly illustrates the relationship between the diaphragm and the pelvic floor. To screen for this, I'm working on a tool that's being embedded into our EMR, and you wouldn't believe how many committees I've had to jump through. So it's almost there. But currently, if I'm using the PFDI, which is a pelvic floor disability index. And in these patients, just like Caroline said, I'm always referring to a clinical specialist, as it's not in my wheelhouse to treat this. At the bottom there, the urinary distress inventory, these are the questions that I'm asking. So the European Cystic Fibrosis Society came up with some guidelines on functional exercise testing in 2023. Some of the authors were here earlier this week, but I don't see any in the room right now. But anyway, the authors suggested that you should choose tests based on what's appropriate and based on rationale and not the equipment or space that you have. And so I'll go over some of the recommendations here. They still continue to recommend that cardiopulmonary exercise testing is the gold standard because it can measure VO2 max and peak work. And it also can identify limitations or risks for exercising. Another alternative, because that's not always feasible, they recommend the cycloergometer because it can still measure peak work while also giving us some vitals like heart rate, oxygen, and RPE. The authors do recognize that most clinicians are performing some field-based tests, so they did give some guidelines there. They do suggest that the 6-minute walk be reserved for patients with advanced lung disease and during the lung transplant process. They better recommend a shuttle test for patients with mild or moderate disease. I do not do shuttle tests, but they do recommend that the higher level, the 25 level shuttle test be used because it's less likely to be a submaximal test. Otherwise, they do suggest the 1-minute sit-to-stand test, as it's a great measure of strength, muscular endurance, postural control, and dynamic balance. One thing that I thought was interesting was that they no longer recommended the 3-minute step test, and they said that it was non-volitional, it was not paced, externally paced, and that it is submaximal. I use a modified version for my annual assessment. Mine is paced, but I do agree with them that it could probably be a tool in my toolbox, but not used for every patient like I use it currently. But I'd be happy to discuss this, afterwards. This is a really nice visual that they gave. I'd guide you to the why and the who. because I feel like it gives us a nice kind of workflow to follow there. If any of you came to the clinic with a more acute care mind, you really should go out and buy this Ortho Notes. It really has saved me. It's $20 on Amazon. But at first when I came to the clinic, I was like, what is a shoulder or an ankle? It was really, really eye-opening when they're coming in with all this thing. So really, it's nice to flip through and it really has a nice comprehensive list. So I would definitely recommend this. Otherwise, I went over for vestibular symptoms, the HIT, the DHI. I really like the functional gait assessment, and the DGI, their dynamic gait index, is another quick one as well. And for pelvic floor health, I'm using the PFTI. So as it's also been touched on earlier in the conference, but cystic fibrosis bone disease is so prevalent. Karen mentioned yesterday that over 30% of our patients have either osteopenia or osteoporosis, according to the CFF registry data in 2022. It's caused by many things. I think that as physical therapists, we can affect this part of our, or this risk factor by encouraging more physical activity, and particularly resistance training or weight-bearing activity. And so in my practice, I'm looking in their chart for a most recent DEXA scan. I'm looking at their labs for vitamin D or calcium. I'm looking at their med list. I'm looking for things like if they've been on a lot of corticosteroids, if they're on immunosuppression or have been on immunosuppression, because that can cause bone resorption. I'm looking if they're already on biphosphonates, which can help build a good bone tissue. Otherwise, I'm typically doing a falls risk screen because, as we know, these patients are at a higher risk for fractures if they fall. So I'm giving them either the falls efficacy scale or the ABC, I think is activity-specific balance confidence scale. For a balance screen, I really like to go for the single leg stance because all of our mobility and walking is a single leg. So that's the one that I go to no matter what age they are. My other go-tos would be a tug or even a tug cognitive, 5 times sit to stand. The FGA is really great. Other tests are mini best tests, DHI. I have a lot more, but I'm blanking right now. But if either of the screenings come up positive, or if patients, have a DEXA scan that shows that they're osteopenic or have osteoporosis, I'll refer them to an outpatient PT. The reason that I'll go into later is that sometimes they need a little bit more follow-up than I can provide. Also, anyone with a new diagnosis who have lab abnormalities, meaning the vitamin D or calcium, or if they have hormone abnormalities, it can be helpful to refer to an endocrinologist, which we've done, and that's been really helpful in our clinic. So one of my geriatric clinical specialist colleagues referred me to the Bone Health and Osteoporosis Foundation. They have a lot of really good resources for both clinicians and patients. Most recently, I've been sending everyone the Boning Up on Osteoporosis. It's a really large PDF, but it gives a lot of great information, especially for those new patients with osteoporosis on all facets of bone health. Otherwise, I'm not a podcast guy, but I've actually started listening to the Bone Talk podcast. Again, it's by these same people at this foundation. And it's about once a month from clinicians like PTs, nutritionists, physicians, but also patients themselves. So you should check it out. Lastly, I do refer out a lot of times. At first, I felt like I was incompetent when I first joined the clinic, and then I couldn't, help them. But I realized that the standard of care right now is visits 3 to 4 times a year, and that soon may change to be even less. And so a lot of people are coming in and they need more follow-up than I can provide. So this PT Finder by the APTA is really helpful. You don't have to be an APTA member. For those of you looking for pelvic floor therapists, the Academy of Pelvic Floor or Women's Health also has a pelvic floor finder, so you can go online and look for that. Otherwise, I am referring to our physician colleagues. I listed some of those up there for you. I also think that pulmonary rehab is an underutilized resource, especially for our patients with advanced lung disease. And so this livebetter.org is a pulmonary rehab finder. Here are some resources for some of the things I talked about today. So some nice links for you to look at afterwards. And here are my references. Thank you for hanging tight.
Bo, you had great resources on there. Would you mind backing up to this
Back it
slide?
up,
Because I
yeah.
have a feeling some people might have wanted a shot at that.
Yeah, sure. I'd be happy to send it out afterwards as well.
Happy to take any questions on the at the mic on the floor or through the app. So I'm going to start with one from the app. The Sainer article talking about the 3-minute step test is not externally paced, but the only version of the 3-minute step test I've ever known is externally paced. Is there a separate version in Europe, an older version that wasn't externally paced?
Yeah, I actually tried to do the same thing once I realized. I was like, wait, I am using the step test, but it's paced. I did not find another version of the test that is not paced. I found other versions that are paced at different cadences. I typically use 120. I think the YMCA uses like 96. I think there's another in the next talk about research. I think someone's going over using the YMCA step test. So that might be something to head to. But no, I didn't find one that is non-paced. I didn't know if anyone in the audience knows of that either, but I have not found one.
Great. The Bone Health and the Bone Health and Osteoporosis Foundation, is that a adult-only resource, or are there pediatric resources as well? No.
It's mainly geared towards adults, to be honest. Yeah, it's mainly geared towards adults. That's not to say that there wasn't one or two resources that could be helpful for kids, but mainly for adults.
You gave a lot of great resources and ideas for a very comprehensive exam. When you find someone who has impairments, when are you rescreening? And I guess a two-part question. Then, do you have any like absolute go-tos when you have a limited amount of time?
Yeah, so for those of you who haven't done the PEP training, I would really recommend doing that with your clinic. Typically, I will start each session with, "Hey, what do you want to talk about, or what is bothering you?" And if one of those come up, that's what I'm focusing on, because a lot of times I go in with my agenda, but their agenda can be totally different. In terms of follow-up, our patients will typically come 3 or 4 times a year. So in a patient that I feel I need to follow up with, I will try and follow up either via email, telehealth, or definitely at the next clinic visit. But it's also going to depend, I'm sorry, I know this answer kind of stinks, but it's going to depend on what it is, their impairment.
Oh, sure.
Hey, Alan.
I'm sorry.
Yeah. that's
Excellent talk, Bo. I loved it. I just was coming up because I was going to comment on the step test. I think the Sainer article was more about that it wasn't progressive and that it was paced at such a low rate that there was like a low, I always mix this terming up, ceiling or whatever effect. So it wasn't effective enough. And then I also want to, because I know people are the YMCA and something, that A step that's out from Brenda Button is a great test, and it's been validated more with adults. That if someone's looking for a progressive test, and I know for some of the people that were at the meeting, we're doing that at Hopkins. We started to try to do it with pediatric patients, but there's some literature on it. There was a talk yesterday about it. If you guys have questions, you can come find me too, but I'm not an expert on it. I'm just like using it, but it's great. It's 16 minutes if you max out. It's supposed to be a max test, and her talk yesterday was showing that it correlated with CPET. So I think it's a great, if people are looking for another test. I'm a little biased, but I think it's much better than a sit to stand measure. Although you are getting leg strength has to be in it as well for completing it, but easy to put into your phone on an app. You just need a step. So space is not usually a limiting factor as well. So that's all. Yeah. No, I think that would be amazing. Like that would make it more like
Yeah.
analyzing. We're not analyzing gases or anything like that. Although looking at that, I was like, I need to talk to our RT to see if we could I just want to see what it would look like. Like, but no, we have no plans to do that or no. I mean, we're just using it as a field test. But from her study stuff yesterday that she was showing and they're working on just showing that it does correlate. What they were finding with doing gas measurements was correlating more with the CPET. So that could be something that is utilized. But there's like 30 step tests. So whatever works best for you. But I think the YMCA, isn't that you change the step height or you're changing the...
You can.
Yeah,
Yes,
and
yes, you
this one
can.
just has a stand, which also makes it simpler for you as a clinician, not having to go through that. So again,
Multiple steps.
I'm not selling anything. I'm just saying that's another potential test out there. So,
Yeah, thank you.
but great talk, Bo.
Brenda's was really excellent too. The study was really interesting and she's very intelligent. So if she's still here, make sure you go up and chat with her.
She is here. I just saw her downstairs.
Oh, great. Yeah.
She's talking at the next workshop. I think.
Very approachable. Yeah.
Absolutely. Awesome. This is great. I'm just here to scope out the little baby. She's too cute.
She's adorable.
Yeah. So, in our clinic for the peds, I just wanted to say before it ended, we actually screen our peds from 8 to 17 for bone health. It's 5, and I'm going to blank on a few of them, but if they had a history of fractures, a certain number of corticosteroids in a year span. There are 3 others, and I'm blanking on them right now, but there is a screen that we do, and if even one of those is positive, then we recommend a DEXA scan for the kids. And I don't know if there's a name for it. It's through the CF Foundation. Okay.
Yeah.
Yeah, so we're using that.
Okay.
Okay.
I know that I didn't mention it, but our clinic, for a DEXA scan, it's like a low FEV1, corticosteroid use. We use like a drop-in weight, and I think it's based on their BMI as well. And there's one more that we also use.
But there is a BMI, and it's like 10%.
Yeah.
Over a year, or 10 pounds, or something like that.
And that's triggering us to do a DEXA scan. Yep.
Okay. Thanks.
Thanks, Matt.
Thank you so much, Bo.
Cool. Thank you, guys.
Right.
Okay, we have our final presenter, Abby Good. She is a pediatric physical therapist at Children's Hospital, Colorado. She joined the CF team in 2017 and is involved in numerous quality improvement initiatives to improve the care of those with CF as it relates to gross motor development, GI management, and group therapy. Her work on gross motor screening was published in Pediatric Pulmonology, and she has also participated in the Partnership Enhancement Program and the CFF Mentorship Programs. She does other things too, but we don't have time. And a fun fact for Abby is that she taught adaptive windsurfing to adults and children as a summer job in high school and college, which is really cool. I want to hear more about that later. All right, please welcome Abby.
Thanks for that intro. Hi, everyone. I'm Abby. It's nice to see you all. I'm excited to be here. I'm the closer for today, and I grew up outside of Boston, so it kind of feels like a nice homecoming to be back. I have nothing to disclose as it relates to this presentation. So my objectives today, I'm very cold, so I'm going to be rubbing my hands, but I want to highlight the unique nature of being a physical therapist for people with CF. We're going to discuss some communication strategies to support participation and goals. We're going to explore the literature to really refocus some of our efforts in caring for people with CF. And then I'm also going to review some of the current grant funding and resources for people with CF to overcome some barriers and optimize participation. So, let's get started with this. I like this. I think we all need this because I think as a discipline, we totally rock. And we have tons to offer our patients. From my perspective, becoming a physical therapist, I really want to help people and I want to make a difference in their lives. And I think we can all relate to that as healthcare providers, but especially as physical therapists. And so kind of with that goal in mind of helping, I want to think about having a jar. And our jar, we kind of fill up with our tools and our knowledge. We take continuing ed to fill our jar. We come to conference like this to fill our jar. And our jar helps us engage with our patients and help them. So we're going to kind of think about this jar and filling it up and how to utilize it when it comes to patient care. So as PTs, caring for people with CF, we have a ton to offer. This is why we're on the CF team. We can help with posture, vestibular system, we can dose exercise, we can help people with pain, work on balance, bone health, pelvic health, strength, developmental skills, mobility, breathing, joint mobility, airway clearance, and my colleagues who spoke before me really teed this up. I just want to highlight it. Like our jar is full of skills and tools for our patients with CF. And then we read articles like this, the impact of habitual physical activity on exercise capacity as it relates to the quality of life of our patients. And we see that FEV1 and exercise capacity are the most important determinants of health-related quality of life. And that avoiding sedentary behaviors positively influences people's quality of life. So our jar is just, it's filling up, okay? And it's overflowing, really. we have tons of skills and tools. But I want you to think about that jar being really full when you enter a clinic room with a patient. We have this jar of skills and we have a lot of eagerness to help and excitement. And sometimes we can overeducate. We can talk too much. We can be a little bit pushy, and we can dump our jar in their lap and expect to make progress and make changes for them. And that's just not realistic. So I want to kind of think about having access to this jar, maybe putting it in our pocket and thinking about giving people 1 or 2 morsels with each interaction that we have with them. We really need to temper our enthusiasm and excitement and really figure out what the patient cares about and just give them small pieces of information, okay? Because caring for people with CF is very unique. I worked in outpatient orthopedics before in the schools and early intervention, and this setting it's been different than anything else. We get to see our patients throughout their lifespan and build a long-term relationship. You see them as babies. I'm in pediatrics, and now I'm watching them, go into kindergarten. And so we really get to work with them throughout their lifespan. We're a continuous presence in their medical journey. We're there when they're ready for us and when they are ready to make a change. We can help develop their toolbox over time, based on their goals and their health status. So again, it's like that little morsel, one at a time for our patients to help them develop their toolbox. And then what's really cool is that it's recommended that we do an annual evaluation for all of our patients. So we have this touch point yearly, and it's such a great opportunity to educate, to collaborate with them, to really understand what their strengths are, what they might need to work on, and really partner with them and maybe we give 2 or 3 morsels during that eval. Okay, so it's just a very unique setting, and I think it's pretty darn cool. So this kind of got me thinking, we get to know our patients over a really long period of time, but how often do we even see them in a year? The frequency. So let's say, we have a patient we see 1 time a year. Maybe we see them for 30 minutes in a year, which is not very much. Some people even only have 20 minutes. Then, maybe we see a patient quarterly in clinic and we're up to 120 minutes. And then there's scenarios where we see them during their admission and then we see them during clinic and we're at 270. Then we see them in clinic and maybe we want to do a burst of outpatient therapy if we have that ability. We see them for 6 weeks to work on something. We're at 480 minutes. And then a patient that we see in clinic for outpatient and inpatient, maybe at max, we see them 600 minutes in a year. Now, there's 525,600 minutes in a year. So there's a lot of time that they're not with us. We have this little sliver of time. And I'd like to encourage maybe one of our morsels that we give a patient is some tips on how to participate and recreate. So how are we going to do that? There's a lot of time in people's years, and we need them to be participating in their lives. So, as we're thinking about this and our morsels and how are we going to address kind of motivation and getting change to happen. So this is a cool article. It was actually done at Boston Children's. It was published in 2015, and they interviewed adolescents with CF and their parents, and they kind of looked at the barriers and facilitators to motivating adherence. And the barriers, I think we all know these: the time, competing interests, their awareness of disease trajectory, privacy, and a lack of understanding when they miss a treatment. So, this is a habilitative approach to care. It's hard for people to understand when you miss a couple of treatments, what long-term things can happen. So those are our barriers, but our facilitators, understanding the importance of therapies, relationship with the CF care team, I really wanted to highlight. If we can build a relationship with our patients, maybe we can facilitate more adherent behaviors. So that's the one I really wanted to highlight. These teens also wanted to be treated like an adult. They thought developing early self-care skills was helpful, and then building routines. So let's keep all these things in mind when we're thinking about our morsels. Okay, so I wanted to, I'm going back, kind of offer some communication strategies in an effort to build a relationship with a patient. In our annual evaluation times, these are some of the questions I tend to ask, and they're open-ended questions. They don't lend themselves to the yes-no answers that we can sometimes get. So just some food for thought here. What have you been doing lately that's helped you move your body? What's something you want your body to get better at doing? Tell me about an activity that you've been wanting to try. I've been hearing pickleball a lot lately. What's your favorite thing to do with your friends or your family? Or tell me about the things you enjoy doing outside of work or school. So, this is a fantastic article, and it's going to really help us rethink physical exercise training to support long-term participation. Okay? So, incorporating regular exercise into the daily lives of people with CF is challenging. So, know that and be patient. It's beneficial to train the neuromuscular system of children with CF to support long-term participation. So Kathy explained that really, really nicely. Like, we need to have a really solid foundation of gross motor skills to have long-term participation. The emphasis for children and adolescents with CF should be to participate in sports. I think this is, as opposed to formal exercise training. So I think this is really important for us pediatric therapists to keep in mind. Sports, recreation. For individuals that do have more advanced disease, formal training should be used. We need to design programs that are individualized for them. And then it's crucial to incorporate an individual's preferences. So that's where we come back to those questions that I ask, like, what are they interested in doing? So I wanted to talk to you about a couple grants that can help us support our patients getting involved in sports and recreation. So here's one called the Salty Life Activity Grant. And I just want to say, I did design a handout that you can download in the app that has all of these resources and these QR codes. You can print it off and bring it back to your clinic so it's there for you. Don't worry about writing all this stuff down. So this Salty Life Activity Grant is catered towards pediatric patients. You get $250 per year to cover the cost of any activity: sports, dance, gymnastics, camps, music, theater, and academic clubs. So this is a cool one. The Breathe Strong Grant. This is an exercise grant. You can apply year-round and get up to $750 in funding. And they'll pay whatever you're interested in, sports, memberships, they pay directly to whatever your interest is. I've heard of people getting equipment, like trampolines, treadmills, really cool offering. So you do need a medical provider to verify that you have CF as part of your application. So you might be getting some, I get a lot of MyChart messages about that, so. Here's another grant. You get $750 a year. It's called What's Your Gap Grant. There's a shorter application window, but it funds similar things: sports, equipment, camp, lessons. And the application's short, a written application, and then you have to do a 2 to 5 minute video. So pretty manageable for our families. And then this grant, it's called it's Piper's Angels is the organization, but they have a Forever Stroke Scholarship. And this is kind of catered towards saltwater activities. So if you live on the coast at a CF center, this is a cool one to keep in mind. They also have some urgent financial assistance, a peer-to-peer program, and they have these 2 free 8-week virtual meditation and breathing programs that looks really cool. And I learned about this recently, so that's another cool offering. So let's dive in a little bit more. So this is another article, qualitative study just published this year in Pediatric Pulmonology, and they interviewed people between the ages of 21 and 60 and asked about what their preferences and perspectives were regarding telehealth exercise. And 3 major themes arose. 1, intervention should be tailored to the person with CF. So we're really, this is a theme, okay? The second one was, there should be opportunities to maintain connections with peers that have CF, as well as the CF multidisciplinary team. And the third was, they wanted a way to monitor their progress over time. So these are things we should be keeping in mind when we're giving those morsels in clinic. They also wanted a variety, they wanted like yoga, Pilates, lots of variety. They wanted it to be convenient and flexible, okay? So things to keep in mind. So I'm gonna play this little video. The Pulmonary Performance Institute has some awesome programs, and Taylor Lewis has been at conference. He runs it, and he has a lot of knowledge in CF. So I hope this isn't too loud, but prepare to feel pumped when you watch this. Turn it up. So yeah, 5-week program, 3 workouts each week. So it's flexible, convenient. You can monitor your progress over time. Then you get access to peer support as well. So it really, again, checks a lot of those boxes. This is a great resource, and I think it costs $49. So pretty manageable. You could use a grant to support paying for this as well. Really good one to check out. There's a core sort of track, and then there's a breathing track. So cool offering. And I, again, familiarized myself with all this stuff as I was preparing for the talk. I didn't know how robust his program was now. Super cool. So bravo, Taylor. Oh no, not again. Okay, some other ones to keep in mind. Breathe Strong Plus, we actually learned a little bit more about it earlier in conference. So it's a year-round virtual wellness program focused on fitness and nutrition. And you actually get an activity tracker when you join this program. And it's a points-based program that goes towards incentive prizes, gift cards. I think they give out an Aflo vest too for one of their prizes. So this is a really cool one if people need a little dose of motivation, they want to connect with peers and monitor their progress over time. CF Yogi is also a fantastic resource. They have live virtual yoga classes. It's free for all people with CF and their family members. And then all the instructors either have CF or have a family member with CF. So this is a really cool one. And again, it gives that flexibility. You can do it from home. So both of these resources are great and help us achieve a lot of the things that patients are asking for. Rock CF is another great resource. They have a ton of stuff, programs, events, education, and community building, but they also have a Kicks Back program where they donate running shoes to people with CF, and then they'll register them for a race of their choice. And when we think about monitoring progress over time, working towards a goal is a really good way to monitor your progress. So this is a really neat program. So Beam, let's see, they have adult classes, exercise classes, educational things, and that's on the left for you. It is available through the end of the month, so get on there now and get registered. They may be extending it for a year, so it's still absolutely worth checking out before the funding kind of, I don't know, it's a little unknown, but I would get on there and check it out. And then they have youth classes as well, and all of those have gone on YouTube and they are free. And there's a whole library of things. There's mindfulness, there's exercise classes, there's airway clearance stuff. You might see my face on there too. So that's a really cool resource for families. So again, convenient, flexible, and led by people that know a lot about CF. So it's almost like having the multidisciplinary care team behind you when you're doing, when you're getting involved in Beam classes. So. Now, Coach Kevin, super cool guy. He is also on the CF, the Beam Youth stuff. He does a lot of classes, so check him out on the Beam Youth program and see what you think. He's super fun. But he has a PE project. It's 26 on-demand videos. It's $65, and I think of like my kids that I see that are homeschooled. This is a fantastic resource because we need to be building their gross motor skills. And sometimes in the home environment, I think that can become hard. So these are awesome. It's caters to kindergartners all the way through middle schoolers. So this is a fantastic resource. And Coach Kevin, he's the man. He's super fun. And he also has children with CF. So he knows about the CF community. He's invested in it. These are just some other ones that I tell my patients about depending on what they're telling me. Just some more morsels. Yoga with Adrienne's great. Cosmic Kids Yoga, both free on YouTube. Planet Fitness offers free memberships for teens in the summer, so check that out. And I always feel like local rec centers are really willing to work with people on memberships. If you're a student, you can get a discount. So it's really worth asking. Now, I just dumped it. I basically dumped the resource jar in you guys' lap. So it's a lot, but I really encourage you need to figure out a system to keep track of all this stuff. Like, we are so lucky to have all of these resources for our patients, but it can get tricky to keep track of everything. So what I've done, we use Epic at our center. I've created a smart phrase. I update it regularly. I can drop it in a patient's chart with a dot phrase. And so that has worked really well. And I just kind of update it as things come. And we all get the CF Foundation emails, and there's always little nuggets in there, singing programs, public speaking programs. I throw it all in my smart phrase. So figure out a system. And maybe your system is print out my handout I made, laminate it, and bring it into the room and let people scan the QR codes and have at it. So figure out a system. So in summary, take time to get to know your patients and help them with their goals. One of the biggest facilitators in adherence and self-care behaviors are an individual's relationship with their CF care team, and that's us. It's vital to incorporate people with CF's preferences into their programming. People with CF are accepting of virtual exercise options, so don't write that off. It's a really good option for a lot of people. Sports should be encouraged in children with CF. They're amazing resources, like I said, so figure out what your patient's goals are and utilize them. And our ultimate goal as physical therapists is to partner with our patients and help them to participate and recreate. So Here are my references, and I can take any questions that people have.
Fantastic, Abby, and thank you for ending our session with such great enthusiasm. I will be honest that I shamelessly stole your idea of the dot phrase to incorporate into my action plan as we were preparing for this, so I will put an extra plug for that. I'd also put an extra plug for using the PT listserv. We're a great community and we can share these resources as we find them. It's impossible to keep track of all of them.
It's hard.
So as just a plug to the audience, that if you find out of other resources, share them on the listserv so that we can all have access to them for our families. So, but any questions for Abby?
Can everyone hear me?
They have asked, because they're recording it, if you don't mind speaking into the mic, apologies. We can hear you, but.
Hi.
Hi.
A little loud. I just have a question. So I live in New York City, and space is definitely something that's a limiting factor. Even giving kids home exercise programs, I have families of 4 to 6 people sometimes living in studio apartments. These kids don't have a space outdoor or indoor. How do you best recommend trying to get these kids to participate in exercise and sport if they don't have the space or the financial resources to do that? A lot of these kids barely can pay for we're paying for their clinic appointments to show up.
Yeah.
They are not attending these youth activities or participating in sport. And I just have a really hard time with this lower socioeconomic demographic of how to get them exercising when it's not culturally important to them from that standpoint, and space is a limitation. I just wasn't sure if you've come across that in your clinic setting.
Sometimes I think the Beam CF Youth program is really worth checking out because it is free. What I like to do is pick a video to do in clinic with them so they kind of get a feel for it. And then I would try and loop in siblings too, because if someone lives in a big family, they're home, they don't have a ton of space. If you can get them to do stuff with their siblings, or even teach them a couple partner exercises to do together so they're not just in isolation doing it on their own, I think that's a really helpful tool. And I also think too, hopefully the schools are helping them with some things, after school stuff, PE, I don't know, all that. But it is challenging, and we have a lot of hurdles. This is a barrier that wasn't even listed in that article. Space and time, and So I would try doing some stuff with them in the clinic room.
Thank you.
Yeah, thank you.
That's a great question. And just to piggyback on it, I'm curious if you know of resources in non-English languages.
Yeah. Do I? Shucks. No, we translate a lot of our stuff, but all of these resources that I talked about are all in English. But I don't know, YouTube, I haven't dug around, but I feel like there's probably some good YouTube yoga that are in different languages. But that's a good question. I know that is another barrier. Does anyone else know of any resources that are in other languages they've come across? No.
We all have some homework, I guess.
I know, right?
Well, if there are no other questions, we thank you all for joining us this morning. I thank this awesome panel of speakers for sharing their knowledge. Hope you all have a few treats in your jar or extra tools in your toolbox after joining us this morning, and enjoy the rest of conference.
Thank you.